Assalamu alaikum wa rahmatullahi wa barakatuh. Bismillahir Rahmanir Rahim. Today we are focusing on food and health. Our tarbiyah for today is on food and health. Narrated by Nabi sallallahu alayhi wasallam, the stomach is the home of disease. Diet is the main medicine. The worldly life is one of the stages of the journey to Allah subhanahu wa ta'ala. And the body is the vehicle for this journey, whereby the traveler maintains the body in optimum condition so that it is not diverted from its goal by any discomfort and pain. One eats and drinks to protect the health of his or her body so that he is able to worship Allah subhanahu wa ta'ala. Some commentators think that most diseases develop from what goes into the stomach. Example, we know that overeating leads to obesity, which predisposes one to diabetes, hypertension, hypercholesterolemia, which in turn leads to strokes, heart attacks, and many other diseases of the body. From an Islamic perspective, we should implement the following as a way of life. A. Moderation in eating. Based on the following hadith, it would be prudent to stop eating whilst still hungry. One portion of the belly may be filled with solid food, one portion with drink, and the remaining portion must be left empty. A balanced diet, many verses in the Quran, recommends foods which will fulfill one's daily protein, carbohydrates, fats, and vitamin requirements, as well as many ahadith describing foods that are permissible on land and from the sea. Few etiquette of eating from an Islamic perspective, partaking of halal and wholesome foods, washing of hands before and after eating, eating while seated on the ground, a sunnah of the beloved Nabi sallallahu alayhi wasallam and his companions. Scientifically proven that this position compresses the abdomen so that one eats less. Last but not least, always mentioning the name of Allah subhanahu wa ta'ala. Today we have in the studio, our guest is Dr Ismail Moola, a senior consultant at the Charlotte Makeke Hospital, and Dr. Moola will be speaking to us on colon cancer. Dr. Moola, we welcome you here today, and
thank you so much.
We would like you to introduce the subject of colon cancer, which seems to be a common topic these days.
Well, colon cancer is something that is happening with increasing frequency throughout the world. And what we are noticing is that we are seeing an effective treatment and effective screening is available for it now. And I would like to highlight over the course of today some of the aspects that we can do in terms of screening, in terms of diagnosis, and then we may go on to some treatment things as we see fit and as we go along. So what is a cancer? Maybe that's always a good place to start, because even cancer, it's such an evocative word, it's such an emotive word. And cancer, a cancer is an uncontrolled proliferation or growth arising from a set of abnormal cells which abnormally divide and replicate and are not subject to the normal forces in the body that prevent this. When it happens in the colon, consequently, it's colon cancer. And we consider cancer of the colon and cancer of the rectum as one disease, and we refer to it as colorectal cancer.
Dr. Ismail, we're finding that a lot of people are being diagnosed with colon cancer. Would you say that there's an increased incidence in this disease?
I think definitely. Cancer is obviously a disease of middle-aged and elderly people generally. you do get younger people. So as populations increase and as people get older, there will be an increased incidence and prevalence of colon cancer going forward. It is estimated that in the United States last year that there were about 50,000 new cases of colon cancer that were diagnosed. And it is estimated that there are about approximately 200,000 people in the United States currently who are alive having undergone treatment for colon cancer, be it surgical resection combined with chemotherapy or radiation in certain circumstances. And this is being mirrored in the South African population as well. We are seeing at the center I work in at Charlotte Maxeke, we are probably diagnosing 2 to 3 cases a week. So in a year, we're diagnosing 120 to 150 cases a week from a single center. That excludes people that have been diagnosed in private. So the incidence and burden is definitely significant and is increasing.
So am I correct in understanding that the high-risk age cohort is above 40?
That would be correct. And what we would like to say is that age cohorts, patients with colorectal cancer and colon cancer, you can pretty much put them into 2 groups. Those with risk factors, that means a relative who had a previous colon cancer, a first-degree relative, that would be a mother, father, brother, sister, a child. And they would be more likely and more prone to get cancer at a younger age. And then the average risk individual. And depending upon whether I as a practitioner or your doctor views you as a low and a high risk person, we will go and then say that you require more intensive screening for colon cancer or less intensive screening for colon cancer. So there are definitely groups that are at increased risk. And I would suggest that the groups at most increased risk are the following. Obviously, if you've had a family history of colon cancer, then you would definitely be at high risk. If you've got a rarer genetic abnormalities, there are diseases called FAP and Lynch syndrome. I don't think we need to talk about those for the purposes of this discussion. They're really the realm of gastroenterologists, oncologists, and genetic experts. And then, finally, we're finding that the black population seems to develop colon cancer at a slightly younger age. And recent screening guidelines from our South African society as well as the American societies advocate we should screen for colon cancer at a younger age in black patients compared to people of other ethnic groups. So
you're saying that at-risk population group, the black population group is an at-risk population group and requires screening at a much earlier stage or phase?
Absolutely. And it's one of the sad facts of medicine in South Africa that often indigent patients don't have access to certain types of modalities, be they logistic, financial, etc. And we really have to try and let people understand that colon cancer can affect everybody right across the board. And yes, it is a disease of elderly, but there are younger groups of people who are affected.
And in terms of risk factors, you mentioned risk factors, but if we look at contributing factors, what are some of the contributing factors? I have heard about smoking and other contributing factors. If you can expand on that, please.
Sure, with pleasure. So what we're finding is that smokers are definitely at increased risk of colon cancer. There's good data from lots of series in the world to suggest that. Additionally, obesity, for some reason, and we're not exactly sure why, is also predisposes you to an increased risk of colon cancer. And I would say, and then they say that, and those are the major negative or things that promote you to get colon cancer. But then similarly, there are potential preventative and protective agents you can get to prevent your risk of developing colon cancer.
And if you can speak to the protective factors, I think that's very critical for people out there.
Well, I think on a dietary level, there's no doubt that folate supplementation, the same stuff that you would give, same vitamin you would give to a pregnant woman, would definitely reduce your risk of colon cancer. In addition, there is evidence to suggest that low-dose aspirin, at a very low dose, a quarter dispirin a day, may, in addition for the heart benefits that are fairly well known, I think, in the population, will also reduce your risk of colon cancer by up to perhaps 20 to 25% in your life, which is substantial. And I would suggest that, and then a good dietary intake of sources high in folate, so that would be green leafy vegetables, spinach, broccoli, cabbage, that would also, they're high in folate, so consequently you would have an increased dietary intake of folate and reduce your risk proportionately.
So all those things would actually assist in reducing. What about the consumption of alcohol? How does that impact?
Alcohol, there is an association with alcohol and colon cancer, but it's generally people who drink in excess. What constitutes excess is a different discussion, but there is an association with alcohol intake and colon cancer, yes.
And you mentioned about the folate, so vitamins, the role of vitamins or vitamins, how does that assist in prevention?
What vitamins do is they act as antioxidants. So what that means is that the vitamin mops up free radicals, things that are carcinogenic, and consequently, by mopping up these free radicals, these carcinogenic substances, and you can reduce the likelihood of a tumor, of a cell being exposed to a cancer-forming agent or cancer-forming substance. And folate seems to reduce that.
Okay, so it has a huge role to play in prevention.
Very much so, yes.
We will take an ad break now and return to Health Matters on colon cancer. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome back to Health Matters. We have Dr. Ismail Moola talking on colon cancer.
Right, so often patients can present late. But in those patients who present earlier, the things we're really worrying about are change in bowel habit. That's a major issue. If your bowel habit has changed and you become new onset constipated over a period of a few weeks, that is something that would trigger an alarm bell in my head. The other thing that I would be concerned about is weight loss and the passing of blood in the stool. The other thing also is if you go to your general practitioner and your general practitioner finds that you're anemic and you're not a menstruating woman, then I think you're actually mandated to go and look and exclude a colon cancer in that patient. And in those patients, a gastroscopy, a scope from the top, and a colonoscopy are probably indicated in those patients.
So, what would be an appropriate age where you would recommend that patients actually go in for regular screening or go for regular colonoscopies?
In the American guidelines and our society guidelines in South Africa, we recommend that patients go for screening colonoscopies at the age of 50 years old. And then consequently, they should have a repeat screening colonoscopy at the age of 60 and then again at the age of 70. The reason for this is as follows. Is that colon cancer, it comes from a pre-malignant condition called an adenoma, a small growth, that given a period of time can go on and form a cancer. So at the time of colonoscopy, if you've got a small adenoma, you can remove it at the time. You can take away this pre-malignant condition, this pre-malignant growth. There's evidence for this as well. And we've seen in America that because they've got widespread screening colonoscopies, with about 80% of the population now being covered, that the actual number of new cases of colon cancer has stabilized and in some parts of America has actually decreased now as a result of a screening colonoscopy program.
We hear of colon cleansing and numerous colon myths. Can you speak to that, please?
Yeah, colon cleansing is an ancient practice that was practiced from the Ayurvedic tradition and from complementary and alternate medicine. I have limited experience with it, but there are lots of people who use it. As far as I'm aware of, there is no scientific evidence that I can find that I'm aware of that shows that colon cleansing And colonic irrigation actually assists on any level in terms of colonic health.
So there's no empirical based evidence to support this?
Nothing. It may be anecdotal, but there's nothing that I'm aware of that can show. And the problem with these type of therapies is, how are you going to test them? Will you enroll a patient into a trial to see for a regular colon irrigation program? I'm not sure patients would find that palatable.
And then the colon myths?
I think things to be concerned about with colon are things like flatulence, gas, etc. Diet does play a role, there is no doubt, and dietary modification can. But there is no real evidence to suggest that, other than obesity, and which can predict or potentially give you colon cancer, and eating of green leafy vegetables which may reduce it, that anything really changes. Whether you take probiotics, I think, is really a matter of choice. There are other indications for probiotics, such as irritable bowel syndrome, etc. But and for post-infectious and with antibiotic-associated diarrhea, but that doesn't really apply in terms of colon cancer per se.
Okay. Is there anything else that you would like to inform the audience, that things they should look out for?
I would really like to stress the following things. I think weight loss, a change in bowel habit, an unexplained anemia, and the passing of blood per rectum, or change in your stool consistency, becoming dark and tarry, I think big warning bells. And I think those are things that the general public needs to be aware of, so that they would then need to, I would think, initially see their general practitioners, with referral then to a specialist who can do a gastroscopy and a colonoscopy.
And the use of laxatives, can you comment on that?
Yeah, laxatives, there are lots of people who struggle with chronic constipation. It's a real problem. Irritable bowel syndrome, a spastic colon, it's a real problem. Laxatives have not been shown to increase or decrease your risk of colon cancer. It's really symptomatic. It makes people feel better. And there's nothing wrong with them as far as I'm concerned, provided that they are used appropriately at the appropriate dose under medical guidance.
And some of the slides that you have, could you speak to some of your slides that you would like to be flighted so that we can, people can...
Yeah, I think the first thing is, what does a colonoscopy entail? I think that's always the first thing. Patients, obviously, they have anxiety, they can potentially be worried. Well, colonoscopy is a two-part process. The first part is the day before the colonoscopy, and that requires drinking something called bowel preparation. And there are many commercially available bowel preps available: Clean Prep, Go Lightly, and then X Prep, Colo Prep, Movi Prep, etc. And that requires having a liquid diet and then supplementing this liquid diet with a very, very powerful laxative, where you can drink up to 4 liters of this laxative in order to clean the colon out, so that you can actually visualize the colon. And as the cartoon shows, then the following day, we will give you a conscious sedation, and then we will do a colonoscopy, which entails taking an endoscope, and then passing it through the colon to observe and see, are there any pathologies there? Is there cancer? Is there an adenoma or a polyp? Are there diverticuli? Are there any areas of inflammation or things that we are concerned about?
So any obstructions?
Any obstructions, yes. How long does the procedure take? In good hands, approximately 20 to 25 minutes should be an adequate period of time.
And post-colonoscopy?
You should be good to go to work the following day.
Okay, so it means that basically you're out of...
Work for a day.
Okay.
That's correct, yes. And in addition, we will give you a sedative to have your colonoscopy, and that would be a variety of medications that are administered by the gastroenterologist and or the anaesthetist, who sometimes assists us with these cases as well. to do that so that the patients are comfortable and calm and pain-free while the procedure happens. In terms of your indications for colonoscopy, the important ones, well, as we said, those cardinal things: unexplained anemia, blood passing per rectum, change in bowel habit, and then screening and surveillance, which probably makes up about 70% of all the colonoscopies I do. And then, in addition, if we can just have the previous slide, and in addition, there are lots of diseases of the colon. And I think the major ones that where colonoscopy can assist you are diverticular disease, which is common in elderly patients, as well as patients who suffer from inflammatory bowel diseases, Crohn's disease and ulcerative colitis. And patients with Crohn's disease and ulcerative colitis, those diseases are chronic inflammatory conditions of the colon, and in the case of Crohn's disease, of the small bowel as well. And these can be also construed as pre-malignant conditions, and there are specific screening guidelines for those particular patients. But that is something that really your gastroenterologist will discuss with you and explain to you more comprehensively what that entails.
Just a reminder to our viewers, please feel free to phone in. The number is 011 086 77 00 or 1 or 2 or 3. Please feel free to call. The number is on the screen. Dr. Moola will be available to answer any questions or concerns. Assalamu alaikum wa rahmatullahi wa barakatuh.
Wa alaikum assalam. How are you? How are you?
Alhamdulillah. How can Dr. Moola help you?
I want to pose a question to her, stating that if a person is an incontinent stool patient, then what do you do in that place?
Can you please repeat your question? I think we're not hearing you clearly.
If a patient has an incontinent stool, what happens to them? There's no control.
Okay. That's a Jazakallah. Thank you for the question. That's a very good question. That can be related to a number of conditions. Incontinence could be a neurologic problem. So patients, for example, with paraplegia, they are incontinent generally. It could be, did you have previous radiation or radiation exposure, and that could damage the blood vessels and the nerves in the pelvic area, and consequently could potentially give you incontinence. And then finally, women who've had natural childbirths, potentially if they were unsafe or they had difficult births, they could potentially at a later age be at risk of getting incontinence. That requires quite specialized treatment and management and investigation. And I would actually refer those patients to a surgical colleague of mine for further assessment.
Okay, thank you. Jazakallah. Has that answered your question? We have another caller on the line. Assalamu alaikum wa rahmatullahi wa barakatuh.
Wa alaikum salam. Is that me?
Yes, sister. What is how
My
can
name
Dr.
is Fatima.
Fatima, Dr. Moola.
I have a question.
Yes, go ahead, please.
Okay, doctor. My husband was diagnosed with cancer of the colon. He since then had his colon removed, and the cancer was localized.
Yeah.
His dietary plan going forward is confusing me a lot, because I'm getting different views from dietitians and from people, but his body is asking for certain types of food that's not in the dietary plan. And I don't want to halt his progression, his health recovery, and I just need your advice on that.
Sure, with pleasure. Jazakallah for the concern, sister. I think I need to clarify, does he have a colostomy at the moment or not? I think we've lost the sister. I think the thing is, post-cancer, every patient who's undergone surgery and chemotherapy on some level is malnourished. And these patients will definitely need some sort of supplementation. Often patients, they will cope just with a good diet, high in protein, a good balanced diet, to assist them in picking up weight, because often patients with cancer have lost a fair amount of weight. And a dietitian can be very valuable in assisting you in that process. Patients who've had the entire colons removed have a very different set of problems, because the colon is quite important in terms of reabsorption of water and to some degree carbohydrate as well. So consequently, they may need increased calories and increased fluid in their diet. So I don't want to speak about the specifics of your husband's case without really, it would be difficult to speak to the specifics if I haven't examined him myself, but I'm sure that your doctors are looking after him well.
Thank you.
Okay.
Assalamu alaikum, jazakallah. I think in response to that, so there are certain conditions that will predispose cravings as well when the body lacks it. Is that what you're saying, Dr. Moola?
No.
Okay, maybe just for...
I think what I'm saying is that if you've got a colon cancer and you're diagnosed, you're going to undergo surgery, you will undergo potentially chemotherapy, potentially radiation as well, depending on the grade and stage and the location of the cancer. And as a result of your body being under stress because you've had surgery, you may need increased nutrition with increased protein and increased calories in order to help you regain the weight that you've lost as a result of that process.
Shukran for that. We have another caller on the line. Assalamu alaikum wa rahmatullahi wa barakatuh.
Wa alaikum salam. I just want to know from the doctor, is there a concern if the stool is green?
That is a concern. That probably implies that the person has got diarrhea, and that patient requires referral from their general practitioner to see a gastroenterologist, a medical or surgical gastroenterologist, as well as stool testing to test for any infections. There are other things that can give you green stool, certain colorants. I know beetroot and iron tablets can give you darker stool, not green, but like black stool. But I would think that that would be an indication for referral to a gastroenterologist.
Thank you. Okay.
Does that answer your question, sister?
Thank you so much.
Pleasure.
Okay. So you've made reference to the color of stool, and would that also, would the chronicity or the length of period that stool is seen for, would that affect or have an impact on the diagnosis?
Yes, to some degree in the setting of colon cancer, but definitely more in the terms of colonic infections and colonic inflammatory disease, specifically ulcerative colitis and Crohn's disease. In addition, if you've had blood, for example, you've got an ulcer in the stomach, blood on its own will change its composition through the bowel, and it will change, and if you're bleeding from a bleeding ulcer, it will change your stool from its normal color to a black, tarry type substance, which is extremely foul smelling. And that implies that that patient has probably had an ulcer or a bleed in the stomach or in the esophagus, in the small bowel, and that requires fairly urgent investigation.
We have another call on the line. Assalamu alaikum wa rahmatullahi wa barakatuh.
Wa alaikum salam.
Brother, how can we help you?
I just got a question for Dr. Moola. I just want to know what's the relationship between polyps and colon cancer?
That's an excellent question.
If you're diagnosed with polyps, is it a high risk for colon cancer?
That's a very, very good question. The whole program and this whole drive towards colonic screening comes from research that has been shown that polyps are pre-malignant conditions, which means that with time they can develop into a colon cancer. So if you have polyps, it is suggested that, and it depends on the number of polyps and the size of the polyp. Any polyp that I see that's more than 5 millimeters or has a specific types of characteristic morphology, and when we send it to the pathologist has got any adverse symptom or adverse characteristics on the histology report, will definitely be you would then be put into a higher risk group, and then you would need more frequent screening with colonoscopy. And that depends, and how frequently you get screened is really related to the nature of those polyps and whether they're in the left side of the colon or the right side of the colon. Patients who've got multiple polyps, big polyps, they require fairly intensive screening at 1 to 2 year intervals. Patients with a single small polyp, you can do a repeat, which was completely removed at the time of colonoscopy. You can send the patient and see the patient in 5 years for colonoscopy.
Okay. Does that answer your question, brother? We have another call on the line. Assalamu alaikum wa rahmatullahi wa barakatuh.
Wa alaikum salam wa rahmatullahi wa barakatuh.
Okay, please ask your question to Dr. Moola.
Doctor, okay, I went for a colonoscopy last year, and they found out that I had a ruptured colon. So, I mean, that was okay. But now what happens with me every time that when I eat certain foods, then what happens, I get a running tummy. You know, sometimes it's 1 day, sometimes it's 2 days, sometimes 3 days, sometimes 3 or 4 times a day sometimes. And it's very painful. That is my problem. And there are certain foods like nuts I cannot eat. Sometimes there's some juices I cannot drink. So I don't know, sometimes I don't know what to eat sometimes.
That's a difficult question to answer, brother, because it's dependent on a lot of factors. It could be a problem related to your colon, but it could be related to your diet. Do you have a diet that's very high in roughage? Have you made substantial dietary changes in the last 6 months to a year? It also could be, do you take laxatives?
No.
You see, are you diabetic? That can contribute to it. Do you have any other comorbidities? So it's very difficult over the telephone to say what exactly your problem is. Yeah. I would suggest that the best solution for you would be to go back to the person who did your original colonoscopy or another gastroenterologist and ask them for a professional opinion so they can spend the time and actually you can find out exactly what the problem is, because it could be something simple like maybe certain foodstuffs like high roughage foods, beans, cabbage, etc. could aggravate this, or it could be something related to another problem that you may have.
All right.
Assalamu alaikum. So what you're saying, Dr. Moola, is that certain foods or lack of tolerance of those foods could also contribute, or any other medical condition could result in these kind of symptoms or manifest such symptoms.
Yeah, I think that you, Dr. Omar, you bring up an important point. I think that there's a lot of colonic pathology out there. It's not only cancer. Because the colon, if you eat a bad meal and you were at a function and you ate some mayonnaise, for example, or some seafood that was improperly cooked, you can potentially get diarrhea. And within 3 or 4 days, it'll probably resolve, and you manifest with cramping and diarrhea. If you have dramatic dietary changes, if you're on this extreme weight loss type program, and you now go from eating a fairly typical diet to something that is quite different to what you eat, you will struggle initially. You should adapt with time, but you will struggle initially. In addition, certain medications can also give you diarrhea. There are certain weight loss remedies, for example, that because of their action on how they bind fat in the colon, they can also predispose you to diarrhea. So what I'm saying is that you can't look at anything in isolation.
Indeed.
You have to look at the patient in totality. And it's the duty of your doctor to sit down with you and explain to you what is wrong, to take a good history from you, perform an examination, and then refer you for the appropriate investigations as you require.
And I think what you're saying is critical, Dr. Moola. Never look at anything in isolation. Always look at it in context, and always consult with your doctor. We have another call on the line. Assalamu alaikum wa rahmatullahi wa barakatuh.
Wa alaikum salam.
How can we help you? Dr. Moola is here to answer your question.
Can you hear me?
Yes.
we can hear you.
Okay, doctor, thank you for listening to me. I'm about 70 years old, and I've got a colon problem. I get a lot of pain and a lot of noise in my stomach.
Yes, okay. Thank you very much, ma'am. I think what the lady is elderly patients seem to have a lot of colonic problems. Chronic constipation is reasonably common in elderly patients. The concern always is this a cancer or is this some benign condition like diverticular disease? Diverticular disease is common and may affect up to 70 to 80% of patients who are 80 years old. And at your age, if you haven't had a colonoscopy, I think it would be good practice for you to be referred for a colonoscopy.
Do I go to who then?
Well, then, I'm not sure where you stay.
I'm in Johannesburg.
You're in Johannesburg. You will first see your general practitioner, and then they can refer you to one of the gastroenterology units, either in private or one of the 3 state facilities at Helen Joseph, Charlotte Makeke, or Baragwanath Hospital, depending upon where you stay and your access to transport, etc.
And what must they do? They must take a screening for.
I'm not sure if I understand you, but
must they take a scope out?
Well, initially you will have a consultation, and then depending upon the person that you see, they will probably refer you then for a colonoscopy or some other investigation. Ma'am, it depends, on what they find at the time. It's very difficult to say.
Yeah, no, it is, man.
Okay.
Anyway, you are Dr. who?
Moola.
Moola.
Yes.
Thank you so much.
Pleasure.
God bless you, man.
Assalamu alaikum. We will now go for a short ad break and return back to Health Matters. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome back to Health Matters. We have Dr. Ismail Moola talking on colon cancer. Dr. Moola, we've been focusing a lot on symptoms and worrying signs that patients present with, and that they should actually consult their doctors when they present with these worrying signs. Is it possible for patients to be symptom-free or present no worrying signs? Is that a possibility or a possible scenario?
It's definitely a possibility, and that's potentially why we advocate screening so much. I've seen a number of young patients in their 30s and 40s who've presented with colon cancers, generally on the right hand, not the left hand side of the colon. The right side of the colon is a little bigger than the left hand side. So often by the time these patients present, they could potentially have a big tumor that's been asymptomatic for a number of months, if not years. It does exist. It's not that common, but it does exist. And it's really unfortunate when those things happen, because they're often young patients who are often quite functional. The other way they can sometimes present is that the patient can be asymptomatic and then present with a bowel obstruction, and suddenly one day their colon obstructs, and then they present with an acute abdomen. And consequently then they will need emergency surgery, and then the surgeon at the time of surgery diagnoses this cancer that he didn't suspect that he would find.
Okay. We have another call on the line, and it will be the last call for the evening. Assalamu alaikum wa rahmatullahi wa barakatuh.
Wa alaikum assalam. I'm speaking on behalf of my dad. I would just like to know, what is the remedy for chronic flatulence?
That's a good question. I think the first issue with chronic flatulence is diet. If you have a diet that's very high in oils, fried food, beans, spinach, you can potentially predispose. Your colon is lined by bacteria, and these bacteria, when they're exposed to certain foodstuffs, they are more likely to produce gas, and that will give you flatulence. So that would be, in my experience, the major cause of flatulence. However, if you've got other problems, other colonic specific pathology, or you're on certain other medications, you could potentially develop flatulence as well. I think for flatulence especially, a dietary history is very, very important. And you need to go down quite carefully with your doctor to see, are there any specific foodstuffs that predispose you to flatulence? And because it's a major social problem, and with wuzu, etc., it can be quite socially disabling for patients. I think a careful history is very important for it.
So there's no medication as such?
Sometimes, in a very small minority of patients, we do, in patients with chronic flatulence, find a cause. But in my experience, it's generally dietary related.
Okay, Jazakallah.
My pleasure.
Jazakallah. Assalamu alaikum, sister. We find, Dr. Moola, that a lot of patients complain about flatulence. So what would your response be to that, to patients out there? What should they actually do?
I think, as I've alluded to before, I think a careful evaluation of your diet is important to see, are there specific foodstuffs that predispose you to flatulence. I think that's often the best departure point. Then, do you have any other problems, any other comorbidities? I find patients with chronic constipation, they sometimes have flatulence, but that's mainly because they have major problems in terms of passing stool, and they may benefit from stool softeners or laxatives. After that, if having looked at the patient's diet and having looked at seeing if laxatives have some sort of role or do help in any way, then I think those patients need a slightly more in-depth and in-detail evaluation by the doctor to see specifically what is going on.
Okay, we're coming to the end of our program. I would like you to just quickly focus on take-home messages or to the audience out there.
I think that if you can walk away with 3 or 4 things, these would be the things. The first thing is that screening colonoscopy is important. We know that access is difficult to it, but it's really important. At the ages of 50, 60, and 70, and in African patients, black patients, at the ages of 45, 55, and 65. So that's the first take-home point. The second take-home point is that there are alarm symptoms that we're concerned with colon cancer. The big ones being change in bowel habit, passing of blood from the back passage, and an unexplained anemia. Those would be major things, that, especially in older patients, that would get me concerned. Thirdly, is that colonoscopy is a day procedure and is highly effective at picking up pre-malignant conditions such as polyps, as well as other pathology. And you can see the pictures and you can print them out and download them to a flash drive, etc. And then finally, and I think that people need to be aware of the fact that there is nothing to be afraid of. There's colon cancer survival rates, if you are diagnosed with it, have improved tremendously over the years. There's good quality surgery, there's good quality screening programs, there's good chemotherapy. So for those people who've suffered and who've developed colon cancer, all is not lost. There are new drugs coming to market, new drugs have already come to market, and inshallah it will give you a long and happy and life full of good health.
Shukran dalilan, Dr. Ismail Moola. We now conclude with a verse from the Holy Quran. Wal asri innal insana lafi khus illa alladhina amanu wa amilus solihati wa tawasaw bil haqqi wa tawasaw bis sabr. We welcome you to Health Matters next week, and it's organized by the Islamic Medical Association of South Africa, and we look forward to participation from the audience. Shukran. Assalamu alaikum wa rahmatullahi wa barakatuh.